Thank you very much. Wish you all a very happy new year, and I would like to thank the Academic Ophthalmology Forum for this invitation, and also Ajanta for handling all the logistics. Like everybody knows, all my friends in Kolkata know, I've been happier joining you in person, feasting on some kosher mangsho. But then for this time, it has to be virtual feasting, so I get on with my topic. That is the evolving role of selective laser trabeculosity and some newer developments with regards to it. I have no financial interest to declare. So the mainstay of glaucoma treatment is lowering of IOP to slow or prevent further progression of vision loss. This may be achieved either via medical, laser or surgical means. The role of medical management and its effectiveness is irrefutable, but we know it is intertwined with challenges such as poor adherence, ocular and systemic side effects, poor quality of life, and a negative impact on the success of subsequent surgical intervention. The SLT-B has been hovering about for decades, but uptake as a standard option in the therapeutic armamentarium remains low. And even the guidelines, if you look at the guidelines, they are continue to be either offered as a secondary or a tertiary options in our treatment practice protocols. Other guidelines, such as the APGS, seem to be similar in terms of what they propose and where the position of SLT can be in our therapeutic armamentarium. And the GSI guidelines also follow a similar practice pattern at this point in time. So this poor uptake among physicians, the lack of access, lack of robust data on safety, quality of life, and cost effectiveness was a trigger for Gus Gazan and his team, who conducted the landmark light trial. Basically, they evaluated the role of selective laser trabeculoplasty as the first-line treatment, and their primary objective was to compare the health-related quality of life in newly diagnosed treatment-naive open-angle and ocular hypertensive patients. The methodology involved to selection of treatment-naive subjects with OHT and OAG. This was the 36-month multi-center randomized controlled trial. Arm 1 included patients on routine medical treatment, and Arm 2 included patients who received selective laser trabeculoplasty as a first-line therapy, followed by medical treatment if indicated. The questionnaire that was used for this trial was the Euro-QOL-EQ 5D questionnaire. And as I mentioned, the inclusion criteria was treatment-naive POAG and OHT subjects. Exclusion as required, they excluded advanced glaucoma and secondary glaucomas. They followed a stringent protocol for laser setting and technique. Laser was delivered to 360 degrees of the trabecular meshwork, and the medication treatment protocol followed typical NICE and European Society guidelines. So let's move on to the results. So the numbers that were recruited to each arm were fairly significant and robust, 300 plus subjects in each arm. And at 36 months, the outcome was that there was no difference in the quality of life between the medical and laser-treated subjects. The overall clinical outcome, both the groups had similar visual endpoints, intraocular pressure endpoints, and visual field loss mean deviation. An important aspect of this trial was 74% of the SLT patients remained medication-free at the end of the trial. In terms of adverse effects, there was no sight-threatening complications of SLT. Adverse effects were similar in both groups. Serious adverse events were also similar between the two groups. An important finding from their study and their point of view was the cost effectiveness. They were able to demonstrate a significant cost effectiveness of SLT in their practice environment and treatment. So overall, to summarize, there was no statistical difference between the groups for quality of life measures. SLT, the authors concluded, was cost effective as a first-line therapy. They also published the 6-year outcomes, wherein it continued to demonstrate There is no significant difference in the health-related quality of life and clinical outcome at 6 years. The cost effectiveness persisted. And the other outcomes they noted was the lower disease progression in SLT. 70% of the subjects remained drop-free after SLT even at 6 years. And there were a greater number of incision surgeries in the medication arm, namely more trams and more cataract surgeries were required. Based on this overall outcome, the National Institute of Health and Care Excellence has now adopted a practice protocol wherein in the UK, most patients are offered initial therapy treatment with the SLT, especially for the OHT and the open-angle glaucoma group. I'm just going to cover a brief overview of effectiveness in other glaucomas such as angle closure, NTG, pseudoexfoliation, and secondary glaucomas. Overall proportion of IOP reduction is in the range of between 14 to 20%, and there's one outlier where in siliconoid-induced glaucomas seem to have responded better. So moving on. So I presume a lot of us are aware of this restless innovator, Professor Michael Belkin. He used to be a regular with the GSI meetings, and he continued to recognize the pain point that was gonioscopy. So as he's so restless that he keeps thinking about what new he can do, and he came up with the delivery mode of SLT, which could be delivered using a direct method without the need of gonioscopy. The laser platform was the same, the spot size used was the same. The additional technology that was added to the platform is an image processing algorithm that automatically located the limbus, and the machine was able to deliver 120 laser pulses preset at 3 nanoseconds with the energy of 1.4 to 1.8 millijoules, and this was delivered to the limbus in under 2 seconds. I shall play a video of the direct SLT technology so that you have a better overview of what the technology is able to do.
DSLT is a disruptive technology developed to actively treat the trabecular meshwork. Our treatment algorithm, an active eye tracker, places a 400 micron beam on the limbus, and as the laser energy penetrates the ocular tissue, it scatters, forming a cloud of energy reaching the trabecular meshwork. To better understand, let's look closer. The typical energy delivered per pulse is higher in DSLT than SLT. In DSLT, the energy is directed through the limbus, and in SLT via the cornea. DSLT allows energy to scatter throughout the tissue, resulting in lower energy transmission to the trabecular meshwork. Energy per pulse reaching the trabecular meshwork is similar in both therapies. Multiplying this energy by the number of spots per treatment would result in a similar total energy reaching the trabecular meshwork in both therapies. The resulting effect is a lowering of intraocular pressure. DSLT offers a sophisticated non-contact therapy, effective as a first-line treatment for glaucoma and OHT.
Can I confirm that the audio of the video did play well? I'm also have access to the DSLT, and we are doing the trial in Singapore. I'm just demonstrating this procedure that I'm involved with, and I'm able to be involved with because of the trial that we're conducting here. So overall, the therapy is generally done once the locking of the limbus is done in under 2 to 3 seconds. So in terms of evidence, most recent evidence is from the GLORIOUS trial, which is a randomized controlled trial that compared the direct SLT with SLT. The number of patients in each arm was 84 versus 77. The baseline patient and eye characteristics were reported to be similar to the group by the authors, and the IOP reduction at 6 months was similar proportion in both the arms. And nearly 50% of the patients in both the arms were drug-free at the end of 6 months. There were no safety concerns identified in this study. Currently, the platform is FDA approved, and we look forward to hearing more from the vendors who have taken over this platform, and I guess we'll have information in the next 6 months. In terms of sharing something about the trial that we are doing in Singapore, that is the DSLT for angle closure eyes. Essentially, this is a cross-section. This is a prospective study, cohort study, wherein we are enrolling angle closure eyes that have either been washed out or treatment-naive after iridotomy and have uncontrolled intraocular pressure. All of them receive a DSLT, and subsequently they're followed up at periodic intervals, which is at 1 month, 2 months, 4 months, and 6 months. The overall outcome in our minimal numbers that we have treated so far is that the overall IOP reduction is in the range of 25 to 28% between at 4 months and up to close to 36% at 6 months. So this is the overall picture of the baseline IOP, which is in blue, and the month IOP at month 4, which is in gray in our group of 21 eyes. So to summarize, 76% of the subjects in our study have been medication-free, or 8 subjects required retreatment, and 4 of the retreated subjects remain medication-free at 6 months. There was no adverse events in the trial noted so far. So to summarize, SLT has demonstrated immense potential to keep a patient drug-free. The ease of effective laser delivery through the DSLT has opened up an exciting era for glaucoma management. However, one needs to note that the cost and logistics of including SLT as a primary therapeutic option may not be feasible for every healthcare system and setup. I would again like to thank the organizers and the team for this opportunity. And I would also like to highlight about this new trial, which is the COAST trial, which is probably ongoing, wherein they are evaluating the role of standard SLT. Following the standard SLT, patients are randomized to receive standard SLT as needed depending on IOP control or continual repeated low energy SLT. It'll probably be about 4 to 5 years until we get to know about the outcome of this trial. I'd like to thank you all again and wish you all a year of great control. Thank you.
Thank you, sir. We'll request our panelists if you have any question for Dr. Arun. So, Chandadi, any comments, any questions? Anyone?
A wonderful talk, Dr. Arun, and very informative. How fast can you do a repeat treatment in a case of SLT? And in pregnancy, if I want it to be effective, when should I do the SLT? When the patient is planning pregnancy or when the patient just declares pregnancy?
Thank you. In terms of our practice protocol for now, we wait at least for 8 to 12 weeks to know the initial response before we repeat an SLT. And in terms of, yes, pregnancy is a very challenging thing, and when we are seeing patients of that age group, it's very important to be open and bring up the topic so that they know that if they're planning pregnancy, they can update us so that your timing can be right. I have not particularly looked up about the safety during the first trimester, but overall, I think when we are, laser should be a lot more safer than doing incisional surgery on patients with different trimesters of pregnancy.
I'll request Arun sir, please stop sharing your screen so that we can see you in the full screen. Yeah, thank you, sir. Yes, Surajit.
Sir, I have one question. You just mentioned here that SLT is being tried in angle closure eyes also. So, sir,
Yes.
I would like to know, was there any criteria of how much angles were open after iridotomy? Then you have done this SLT, or even if the angle is fully closed also after the iridotomy, then also the patients were taken for SLT?
Right. So we have done, I've done previous publications on SLT and angle closure, wherein we've published the methodology. So typically we did not include eyes that had a PAS of more than 180 degrees in both the trials. Yes, I don't think there is a role for the SLT to be done when there is a synagogue closure beyond 180 degrees.
Yeah,
Sir, Tomnash here, sir. Sir, you have said at the last, the COAST study, the one which is ongoing. So in that you have said that low energy SLT. So what was the parameter? Like we know about standard 1 to 1.2. So like.
Yeah, I know. I have not looked up the. It is a very new trial that is probably. I'm not sure even if the methodology is published. So
Okay.
I can probably find out and update you. But
Okay.
it should be lower than 0.9 is what I think.
Okay.
Because the starting range generally recommended is 0.9 onwards to see the champagne bubble effect, and then you reduce it by about 0.1 or 0.2. So if I find the info, I will update you.
And sir, like whether to do 180 or 360 in that yearly basis also, like
I think they're doing 360. Yeah.
360-degree yearly. Okay, sir. Thank you, sir.
What is your practice? Arun, what is your... It's not working properly.
I can hear
Arun,
you.
Arun, what is your
Not
practice?
very well though.
Yeah, Arun, what is your clinical practice by selecting SLT patients?
Yes, so I mean, we remember in general we've been tuned to choose patients when they are on 3 medications. We start talking about it, but that has been about 2 to 3 years ago. But in the last few years, we've been able to offer it a lot earlier, and we also noted that we have not paid enough attention to intolerance. So, generally in Singapore. Yes, it has not yet become very common for us to discuss this option in treatment-naive patients. So in a way, it's also about logistics. You need to prepare and plan for laser. There's a whole process: consenting, finding space, finding time, and then you probably choose the easy way out. But then with DSLT in next year's slit lamp or an SLT next year's slit lamp, it's all about logistics and availability and cost. And to an extent, wherever I've seen laser technology used for any kind of therapeutic purpose, the cost seems immense to the patient. You propose the laser, it is like equivalent to a surgery in terms of cost. So till that changes, even our mentality may not change. So it is not equivalent to just giving an alternative to drops.
Good afternoon, sir. Sir, I have one question. Just for my curiosity and just query, sir, if the patient had an history of failed TRAV, so before the second TRAV, can you try the SLT before the second TRAV? If the patient have
Absolutely. Because in every eye, the trabecular meshwork is not 100% non-functional. We also we have a significant proportion of the trabecular meshwork still functional. So it is it's not a practice that is unknown, or it is not something that you should not do. It's absolutely worthwhile to offer a patient a trial of SLT before going through, because we also know the success rate of a second surgery is going to be quite low. So with that in mind, and offering SLT as an option just before second surgery, absolutely fine.
Thank you, sir.
Thank you, Arun sir. Thank you again for joining. Do you have any question? Yeah, I think Vidya, please.
Just one more point to add, not a question. So when we say SLT in a treatment-naive patient, when we are trying to explain the patient the diagnosis of glaucoma, and where we emphasize on adherence of the patient to treatment, starting a drop and giving the patient the responsibility to use the drop and come back is one thing, and doing a laser and telling the patient that you have to come back and show the pressure, the patient has a feeling that I was diagnosed with a disease, I got a treatment, and now I am fine, and may be lost for follow-up. So hence that sometimes does not work in a scenario where the patient may not follow up if we do not start a drop and ask the patient to review back. So that is one concern. If you do the laser at first, the patient thinks that he is treated and may not review back.
Absolutely. There has been a concern all over the world. It's not just about any kind of practice. So we need to be very careful about how we counsel and tell them that this is not a cure. In fact, even the frequency of your visual field, frequency of follow-up should not change too much. It should be based on the extent of disc damage and extent of visual field loss.
Thank you, sir. Dr. Dwashi, you have a question? We can take one more
Sir, I
question.
just wanted to know whether this DSLT is available commercially, and is it available in any center in India?
I don't think it's marketed yet because Alcon seems to have taken over and they've given it a new name. I'm sure we will hear it in the next internet. It's already, I think they've already did share with us, but it should be available very soon across the world. Yes, but it's currently, the technology is under Alcon.
Okay, thank you.
Thank you, everyone.